Dear students, welcome to Bluepen Online. Shall we begin? Please use headset, pen and paper to take notes.
Here you go. Please let's know your feedback after class.
Welcome to Bluepen Online. Next, we'll be discussing about radiographic examination of pediatric dental patients. Myself, Dr. Chaitra. William Conrad Röntgen introduced X-ray in 1895. What are the uses of X-rays? It helps in early diagnosis of caries. Thus, it will prevent dental pain, extraction, and emotional stress, and also eruptive or developmental problems, which will reduce the need for prolonged orthodontic procedures too. And it is also helpful in case of restorative procedures that will require an accurate registration of the pulpal outline that only a radiograph can reveal. Thus, from last section also, we had learned how to come to a final diagnosis. That is, with the help of X-rays or the investigations, we usually come to a final diagnosis. So, radiology is one of the commonly used method in order to come to a final diagnosis. In a radiograph, we see certain radio-opaque structures as well as radiolucent structure. So these radio-opaque structures will be appearing in white color, whereas radiolucent will be the dark or the black in color. And this radio opacity will be depending upon the density of the material. So more it is denser, the more radio opaque it will be. Now enamel, we know that enamel contains more of mineral content. So you can distinguish between enamel as well as dentin. So this enamel will be separated from dentin, and you can also view it in a radiograph. And dentin is also another radio opaque structure, and you can well differentiate it from a pulp, which is a radiolucent structure. So this is pulp, which is radiolucent. And this will be the root canal. Another structure which is usually seen in a radiograph is a lamina dura. So it is a thin radio-opaque layer of dense bone which will surround the tooth socket. So you can see a white line here. So after extraction, you can appreciate the lamina dura. Another important structure is the alveolar crest. So in case of bone loss, alveolar crest is noticed. So usually the location of alveolar crest will be 1.5 mm below the cemento-enamel junction. Now, what are the techniques which we usually use in children as well as adult? So the commonly used techniques are intraoral techniques as well as extraoral. Under intraoral techniques, we have intraoral periapical radiograph and bite-wing technique. Bite-wing is commonly used for diagnosis of proximal caries, and there are occlusal radiograph. Occlusal is mainly used in case of unerupted or the impacted tooth, or also in case of cryolithiasis. Another radiographic technique is extraoral. So in case of extraoral technique, the film will be placed outside the mouth. So in this case, the main commonly used extraoral techniques are TMJ and lateral oblique view, lateral cephalograms, PNS view, and orthopantomography or the OPG. Now, what are the parts of X-ray machine? So in case of IOPA or the intraoral periapical radiograph, we commonly use this kind of machine. So it consists of a timer where we have to set the time, then support arms and a tube head. This full part is called as tube head, and the extension is called as PID. PID is nothing but position indicating device. So within the tube head, we have this structure. So it basically consists of a tungsten filament. So this tungsten filament will be present within a focusing curve. And from this tungsten filament, the electrodes will be emitted. And this is a target. So this target is made up of tungsten and it is angulated at about 20 degrees so that it creates a shorter focal length. And this will be held in a copper stem. So all these will be embedded in a vacuum. So the X-rays emitted from this will be passed through this PID or the position indicating device. So coming to intraoral periapical radiograph, which is an intraoral technique. So where is it commonly used? It is used in order to evaluate the development of the root end and to study the periapical tissue. So as its name suggests, periapical, in order to see the periapex. So we will come to know about the root length, how much of the tooth is formed in case of intraoral periapical radiograph. And it is also used to detect alterations in the integrity of periodontal membrane, to evaluate the prognosis of the pulp treatment by observing the health of the periapical tissues, to identify the stage of development of unerupted teeth, to detect developmental abnormalities like supernumerary, missing or malformed teeth. It is also used for early detection of pathological changes associated with teeth, for space analysis in the mixed dentition, to assess the path of eruption of permanent teeth, and to evaluate the extent of traumatic injuries to the root and alveolus. Please remember at least 5 to 7 uses of intraoral periapical radiograph. Now, what type of films we usually use? So there are various sizes in the film, that is size 0, 1, 2 and 3. So in case of children, the commonly used size is size 0. So it measures from 22 to 35 millimeters. This is commonly used in pediatric patients. And size 1 is used in case of anterior teeth, which measures from 24 to 40 millimeter. And size 2, which is commonly used in adults and is also called as the standard film. So its measurement is 31 to 41 millimeter. And there is size 3, which is bite wings of adults, measures from 27 to 54 millimeter. The other intraoral film we use in case of occlusal technique is a occlusal film. So its measurement is bigger than the size 2 film, which is about 57 and 76 millimeter, which is used for maxillary and mandibular occlusal radiograph. Now, what is a film composed of? It mainly consists of film base. Here's the base, then the adhesive layer, film emulsion and a protective layer. So film base is a flexible piece of plastic which is about 0.008 inches thick to provide the desired degree of stiffness and flatness for handling. And there is adhesive layer, which is a thin layer of adhesive material to act as attachment between the base and emulsion from both sides. Then there is film emulsion. So it is a homogeneous mixture of gelatin and silver halide crystals coated on both sides of the film base to provide maximum speed to the film. So speed means sensitivity. So higher the speed, the more it is sensitive. The halides used in dental X-ray film are silver bromide and to a lesser extent it is silver iodide. So once it is exposed to the X-ray, this silver bromide absorbs the X-rays and physical changes take place in the emulsion. This change is called as a latent image. Now, how do we take the intraoral periapical radiograph? So the commonly used method involve paling technique and bisecting angle method. So questions can be asked from this section. Moving on to each, the paling technique, as its name suggests, the film will be placed parallel to the tooth. So the film will be positioned using the extension cone parallel instrument. So this blue colored material or the instrument is called as the extension cone parallel instrument or film holder, so that the film will be held parallel to long axis of the tooth, which is to be radiographed. And the X-ray tube head will be aimed at right angle to the tooth and the film. So this was introduced by Dr. Gordon Fitzgerald. So in case of paralleling technique, as I said, the film will be placed parallel to the long axis of the tooth, and the X-ray which is coming from PID will be perpendicular to both the film as well as the long axis of the tooth, and hence the name paralleling technique. So what are the advantages? Little magnification, periodontal bone level are well represented, radiographs are accurately reproducible by different operators, but it also poses certain disadvantages, like it is difficult to position due to the film gagging, and may not be possible to place a film in shallow palates. Now, how do we place a film in case of paralleling technique? As I said, the film must be placed based on the long axis of the tooth. So, how the tooth is angulated, based on that, the film will be placed. So, this shows the incorrect method where the film is not parallel to the long axis of the tooth. So, in case of anterior tooth, the film must be placed vertically, whereas in case of posterior tooth, it must be placed horizontally. So, within the instrument or the extension cone or position device, it must be placed like this. So in case of posterior, yellow colored one is used, whereas in case of anterior, blue colored one is available. Coming to the next method of intraoral periapical radiograph, which is the bisecting angle technique. It can be also as a short knot. In this case, the film will be placed close to the tooth to be radiographed using snap array film holder or hemostat. The X-ray tube is adjusted such that the central ray of the X-ray bisects the angle formed between the long axis of the film and the tooth. So this is the bisecting angle technique. So in this case, the film will be placed very close to the tooth. So this is based on the rule of Szymanski rule of isometry, which states that two triangles, so this is the two triangles, are equal when they share one complete side and have two equal angles. So AB represents the film, AD represents the long axis of the tooth, and this AC is an imaginary bisector. So here angle will be equal, and here this is the central ray which will be perpendicular to the imaginary bisector. Now, how do we position the patient? In case of patients, in case of maxilla, it is placed parallel to the floor, whereas to the mandible, the head must be tilted in order to place it parallel. And the mid-sagittal plane will be perpendicular to the floor. There are certain terms related to IOPA, that is horizontal angulation and vertical angulation. So what is horizontal angulation? So horizontal, it is mainly the position indicating device. How do we position it? So this PID must be placed horizontally so that it is parallel to each of the proximal surface. See, it goes like this. In case we change the horizontal angulation, that is if PID is placed here like this, then the X-rays will be emitted like this, but it can result in the overlapping of the tooth structure. So this is the horizontal angulation. So basically horizontal angulation will be based on the PID, how do we shift, either right or left or straight to the tooth of interest. So in case of upper arch, this is how we take horizontal angulation. So it is always better to keep a horizontal angulation in 0 degree. Now what is vertical angulation? So it is the angle formed by continuing the line of central ray until it meets the occlusal plane, determines the vertical angulation of the X-ray beam to the occlusal plane. So it mainly depends upon how we locate the PID, that is whether it is, in case of maxilla, the vertical angulation will be positive, that is PID will be positioning above, whereas in case of mandible it will be positioned below. Now what are the vertical angulation degree we give? So in case of anterior teeth it is 40 degree, and in case of mandible it is minus 15 degree. So as I said, in case of maxilla it will be positive for all teeth, whereas in case of mandible vertical angulation is said to be negative. In case of canine it possesses highest number of vertical angulation, that is around plus 45 degree, and mandible minus 20, premolar plus 30 and mandible minus 10, molars 20 and mandible molars it is minus 5. It differs slightly in case of pediatric patients. So in case of posterior maxillary region, the vertical angulation is about plus 30 degree, and posterior mandibular it is about minus 10 degree vertical angulation, and in case of anterior maxillary it is plus 45 degree, whereas in case of anterior mandibular teeth it is minus 15 degree. So this is how we position the PID. So this is especially in case of maxilla, whereas it is tilted like this for the mandible. So what is the advantage? Film position is easy and comfortable for the patient, and if positioned based on correct angulation, the image size does not alter. But disadvantage include variables are many in this technique, making it difficult to reproduce accurately every time. Incorrect vertical angulation results in elongation of the image, and incorrect horizontal angulation results in overlapping of the images of the crown and root or concut. Periodontal bone level are not clear. Detection of proximal caries is difficult. So let's see what are the difference between bisecting angle technique and parallel technique. So this is also important. Bisecting angle technique, image shape distortion. There can be superimposition of zygomatic process. Anatomical relationship is altered. Crown root ratio is not preserved. Poor image standardization and reproducibility. Whereas in case of parallel technique, there is only slight image size distortion, and there is control of shadow of zygomatic process, correct anatomical relationship, crown root ratio is preserved, high image standardization and reproducibility. The next technique is bite wing technique. So bite wing technique is mainly for the complete visualization of the proximal caries and the upper and lower teeth in single periapical radiograph. So in this case, the head will be positioned such that mid-sagittal plane is perpendicular and the alar tragus line is parallel to the floor. And the lower edge of the film is placed in the floor of the mouth between the tongue and the lingual aspect of the mandible, and the bite tab. So this is the bite tab. It is placed on the occlusal surface of the mandibular teeth. The film will be positioned to cover all the region of concern. So this is one of the bite wing radiograph where it covers almost both upper and lower teeth. And the central ray enters at the occlusal plane at a point below the pupil, vertical angle being plus 10 degrees. So this is how we keep the PID. Vertical angulation is set to plus 10 degree. So this can be even created using paper. This is the bite tab, and this is the instrument which we can use, which is called as Rin bite wing instrument. It is available in certain colors like blue for anterior, yellow for the posterior, and the red which is used for the bite wing. Coming to occlusal technique, occlusal films are used to radiographically clarify the anatomical structures and the pathological conditions of the maxilla or mandible in the buccolingual dimension. So this is mainly used for various purposes like to obtain gross views of the jaws in the buccolingual dimension, for detection and location and extent of fractures, detection of buccolingual direction of impactions and supernumerary teeth, detection of buccolingual direction of displaced fracture, and for detection of salivary gland duct stone and localization of foreign bodies and determination of the shape of dental arches. So here we can see this is one of the occlusal film of maxilla. So in this the impacted canine can be seen. Coming to localization technique, so this question may be asked even in case of brief note or even for the viva. So as its name suggests, localization, this is a method to locate the position of a tooth or object in the jaws. So this mainly will depict the buccolingual relationship or depth of an object. So one of the localization technique is called as buccal object rule, also called as Clark's technique, and some people also call it as side slope rule, that is same side lingual, opposite buccal. And other words used are tube shift localization technique. Then some people even call it as right angle technique. So remember Clark's technique, buccal object rule, slope rule, tube shift localization technique, buccal object rule, and right angle technique. It is called as Clark's technique because it was discovered by Clark in 1910. This helped to locate or determine the buccolingual relation of an impacted tooth or foreign body within the maxilla. So this buccal object rule states that the image of a buccally oriented object appears to move in the opposite direction from a moving X-ray source, and the image of any lingually oriented object appears to move in the same direction as a moving X-ray source. So this picture will tell us everything. So when you keep the horizontal angulation 0 degree, and now this is the lingual object and this is the buccal object. So when you expose it and on the film, this will be superimposed. So this makes us difficult to know whether it is an buccal side or in the lingual object. So for example, in case of premolar, we possess buccal root as well as lingual. So in order to view which canal, so because of the superimposition, it becomes difficult. So we do localization technique where we can shift the PID. So if it is shifted to this side, then the same side buccal, same side lingual and opposite buccal. Now this is the lingual object, and if the image is here, then it is same side lingual, and this one which is actually buccal. So if we in the same here, when it goes to opposite side, then it is called as buccal object. So this is how we determine the position of the foreign body or any buccal or lingually placed objects. So with an orthoradial projection, the two objects appear here superimposed. With oblique projection, the two objects cease to be superimposed and easily become recognizable when the angulation of the X-ray machine is known. The buccal object, the one which is closest to the radiographic source, is displaced in the same direction as the X-ray source. Now this is an example of, now we have, imagine there is a foreign body which is placed lingually, but when we expose, we get it as between the roots. We are not able to distinguish whether it is placed buccally or lingually. Now we change the angulation, and from this we can see there is no change in the position of object after taking radiograph with change in the angulation of the PID. So this suggests that it is lingually placed object. So how do we take is 2 radiographs are required. So first we'll position the patient head so that the sagittal plane is perpendicular to flow and alar tragus line is parallel to the flow. And the first film is exposed, and then we take the second film which is placed in the mouth in the same position as the first film, with the patient's head position and vertical angulations remaining the same. Now horizontal angle is shifted either anterior or posterior depending on the area being examined for the second view. So basically we have 2 radiographs. We need 2 radiographs in order to appreciate the or localize the object. Coming to extraoral radiograph, the most commonly used extraoral radiograph is the panoramic radiograph or the orthopantomograph. So it's an extraoral radiograph in which the X-ray film and the X-ray source will move in opposite directions. So when X-ray source will move to right side, the radiograph will be moving to the opposite side. This is used to visualize the entire dentition and reduces the total number of films and thus reduce the radiation exposure. This is also used to introduce the child to radiography as it is an extraoral radiograph. Totally, it requires about 15 to 22 seconds to record. Although it is considered as a supplement, it cannot substitute intraoral radiograph in the diagnosis of caries or for view in the periapical region. This is also useful in case of handicapped children and for viewing a wide area of the TMJ and associated region. So this is one of the OPG. Here you can see full view of the mandible, maxilla as well as the entire dentition. This is especially useful in case of handicapped children, but the only requirement is they have to be stabilized for around 15 seconds. There are certain other techniques which are advanced ones. So RVG or the radiovisuography, zero radiography, subtraction radiography, computer tomography, cone beam computer tomography, tuned aperture computer tomography, magnetic resonance imaging and ultrasound imaging. So these are the advanced radiographic techniques which we used. So the advantage of radiovisuography is no film is required. Now in case of children, child cooperation is very much essential in order to obtain a radiograph. So it mainly determines or depends upon the selection of correct radiographic technique, and it increases the probability of success and reduce additional radiographic exposure. So this machine will be always threatening to the patient, and this can even develop anxiety and as well as curiosity in the child. So always introduce a machine to the child and desensitize them. So the ideal methods is they should be expose the patient to a minimum amount of radiation and take minimum radiograph as possible, take as little time as possible and provide a diagnostic accurate examination of dentition and the supporting structures. So in order to take and make child cooperative, radiographic survey can be done. So in case of radiographic survey, we'll take certain radiograph which will be helpful in complete diagnosis of the dentition. So there are different radiographic survey. There are 4 film series, 8, then 12 and 16 radiographic survey. So 4 film series comprise of maxillary and mandibular occlusal radiograph and 2 posterior bite wing radiograph. In case of 8 film survey, it includes maxillary and mandibular anterior occlusal radiograph. Then there are 4 periapical radiograph. This is a periapical. It will be 4. And 4 molar periapical radiograph, and 2 posterior bite wings. So all together there will be 8 radiograph. And there is 12 film survey. So in total it is 12. This include maxillary and mandibular permanent incisor periapical radiograph, 4 primary canine periapical radiograph, and 4 molar periapical radiograph, and 2 posterior bite-wing radiograph. In 16 film survey, it consists of 12 film survey, which we already told, and in addition to that, there will be 4 permanent molar radiograph. Now, what are the considerations to be taken in case of young child? The first step is to desensitize the child to the dental experience. Explain to the child what you plan to do in words easily comprehended by the child using a tell, show, do technique. So this is tell, show, do technique. The child is positioned to gain maximum cooperation. In children less than 3 years of age, it is necessary for the child to sit in parent's lap while the radiograph is exposed. Such positioning will reduce the child's anxiety towards additional emotional security and increases cooperation, and also enables the parent to adequately restrain the child and avoid any unexpected sudden movements. And also obtain the least difficult radiograph first, such as an anterior occlusal. This will desensitize the child to the procedure. And correct settings are made on the apparatus, and the X-ray head is properly positioned before placing the film in the child's mouth. We also need to protect the parent and the child with lead aprons to reduce radiation exposure. And if the child is uncooperative, then additional restraint by a second adult may be necessary. A second adult will stabilize the child's head with one hand, while the other hand position the X-ray holder in the patient's mouth. So this is one of the assistance by the second adult. In case a second adult is not available, it may be necessary to place the child in a mechanical restraining device, that is purpose board, to adequately restrain the child. If the child is still too uncooperative, it may be necessary to manage the child pharmacologically with inhalation, oral or parenteral sedative. Older children may also be uncooperative for a variety of reasons. So these can range from the jaw being too small to adequately accommodate the radiograph, or fear of swallowing the radiograph, or they can be fear of the procedure itself, or the patient exhibits a severe gag reflex. As thus, for the child with a small mouth, use a smaller size film available, that is size 0, and roll the film. Do not place sharp ends to allow the film to accommodate the shape of the jaw and not to impinge on the soft tissues. So slightly you can bend the film. Now, how to position the radiograph? It can be placed vertically in the mouth for both periapical and bite-wing radiograph. This will reduce the distal extension of the radiograph and as well as result in greater tolerance by patients, especially those with mild gag reflex. The vertical bite-wing radiograph will provide greater detail of the periapical area. The holder, that is the snap array, is also useful for those patients that have a fear of swallowing the radiograph. So this holder can be used in order to place the X-ray film. By biting on the large positioning device and watching in a mirror, they are assured they will not swallow the radiograph. So this is another method of managing the child. A self-sticking sponge tab may also reduce impingement of the radiograph on the intraoral soft tissue. For patients frightened of the procedure itself, desensitization techniques may be necessary to gain the patient cooperation. Now, how do we do desensitization technique? So it is defined as gradually exposing the child to new stimuli or experiences of increasing intensity. So one of the example is introducing the patient to X-rays by initially taking an anterior radiograph, which is easier to tolerate than a posterior radiograph. Another example is lollipop radiographic technique. So in this technique, the child will be given a lollipop. After a few licks, the lollipop is taken from the child and a radiograph will be attached to the lollipop using an orthodontic rubber band. The lollipop with the attached film is returned to the child, who is told to lick the lollipop again. After a few licks, the child is told to hold the lollipop in his mouth while we take a tooth picture, and then the exposure will be made. Now, what do we follow in case of handicapped child? The physically handicapped child cannot usually hold a film in his or her mouth with fingers. In such a child, radiograph can be taken by the parent holding the child or by the use of film holding devices. If the child is unable to open the mouth, extraoral radiograph such as oblique lateral radiograph should be preferred. Coming to radiation effects, we know that X-rays are ionizing radiation. So the X-ray radiation is its ability to impart some of its energy to the matter it traverses. If that matter is living tissue, then some biological injury may occur. The effects of low levels of radiation on biological system are virtually unknown. There are three primary biological effects of low level radiation. So this involves carcinogenesis, teratogenesis and mutagenesis. So carcinogenesis and malformations are responsive somatic tissues and in most instances are believed to have a threshold response. That is, certain amount of radiation is necessary before the response is seen. Mutation may occur as a response of genetic tissue to radiation and is believed to have no threshold. In general, younger tissues and organs are more sensitive to radiation. So basically, radiation is a cumulative effect. So there are certain critical organs and the associated adverse biological effects. So these organs are skin, red bone marrow, gonads, eyes, thyroid, breast. So skin is more susceptible for cancer, red bone marrow to the leukemia, and mutation of gonads, cataracts of eye, and cancer of thyroid or breast tissue, and also salivary glands. So we need to follow certain radiation hygiene measures. One is proper registration and maintenance of radiographic unit. Then training of personnel who are associated with radiography. And dosage monitoring like dosimeters. Radiation protection of the child patients by using lead apron with thyroid collar. Use of long lead lined cylinder and position cone devices, and use of electronically controlled exposure timer, use of high speed films, use of automatic processing machines that give good consistent result, employing proper technique to avoid the chances of repeating exposure. So we can take radiation protection by using certain methods as we told, like lead aprons, thyroid collar, high speed films, and electronically controlled exposure time, and also use of long lead line cylinder and position indicating device. So one of the measure is high speed film. So the speed ranges from DEF. Faster film speeds have contributed most significantly to the reduction in radiation to the patient. Film speeds DE and F are currently available for intraoral radiography. Faster the film will reduce the error from patient movement. So more like DEF, the faster the film, the less the radiation exposure is required. So the commonly asked question in this section is indication of X-ray, that where is radiation or the X-ray we can use, or indications of IOPM, that is in pediatric patients, especially to know about the root length, then about the eruption status of the underlying tooth and any abnormalities, and about the bone loss. So likewise, you can write about the indications of X-ray. Then about the techniques of IOPA is another commonly asked question. So the techniques of IOPA include paling technique, bisecting angle technique, then uses of OPG or orthopanoramic or panoramic radiograph, then localization technique or the Clark's technique or the right angle technique. Then and the important question in case of pediatric patient, that is management of child during X-ray exposure. Basically show do and about the desensitization and about the lollipop radiographic technique. The other commonly asked short question will be the bisecting angle technique. So that is about the radiological part or the radiological examination of the pediatric patients.